Hello and welcome to this next segment of the UVA Mini Med School COVID-19 podcast entitled Flattening the Curve and Social Distancing. My name is Sebastian Dobrow. I'm a fourth-year medical student here at UVA. I have both the pleasure and privilege of interviewing Dr. Bryan Lewis and Dr. Srinivasan Venkatramanan, both PhDs with the Biocomplexity Institute and Initiative here at UVA. Welcome to you both. We're very happy to have you with us today.
Nice to be here. Thanks for having us.
So by way of brief introduction, Dr. Lewis is a research associate professor in the Network System Science and Advanced Computing Division. His research focuses on understanding transmission dynamics of infectious diseases and has been heavily involved in projects forecasting the spread of diseases such as Ebola, pandemic flu, and cholera. He has also done important work to support the federal government in evaluating public response to such diseases. Dr. Venkatramanan is a research scientist as well, also with the Network System Science and Advanced Computing Division. His research interests include infectious disease modeling and forecasting, and his work centers on developing and analyzing computational models for complex systems, especially as they pertain to epidemiology and food security. Before we get into the segment, I was hoping you, Dr. Lewis, would briefly describe the work done at the Biocomplexity Institute and the Network System Science and Advanced Computing Division in particular. Help us understand why the work you do is relevant to the coronavirus crisis we're all experiencing.
Sure, Sebastian. So at the Biocomplexity Institute, we like to focus on solving real-world problems, mainly computationally. So we aren't as involved in sort of wet science. And we like to say a quick tagline as we look at problems from the molecules to policy. And so we've got scientists in certain divisions that do different mathematical equations to help solve the way that RNA folds, for instance. And then we get all the way up to another sister division that focuses on solving statistical problems for the census or how to allocate fire stations to better respond to 911 calls in different counties. Our division itself is a little bit more focused on using sort of in between the two layers, where we use simulation and network science to represent the world and then answer policy questions or provide real-time response to various crises. And so our work has involved with Srini here a lot of forecasting of infectious diseases, as well as a lot of counterfactual style analyses where we say, if we had this much vaccine at this point in a pandemic, would we be better off if we allocate it in this manner or in that manner? Some of that work is extremely relevant today as the coronavirus has increased cases. We're luckily at a phase where that curve has been flattened quite a bit, and we'll talk more about that, I'm sure. But we still run into these situations where the resources may be oversubscribed, overused, and we would have shortages. And so we can solve these problems computationally, look for optimal ways in which different hospital systems could share their resources, how manpower could be shifted from one area that's experiencing an uptick from another that maybe has had a lull. And so it's those kinds of problems that our federal partners are very interested in. We're also working with the Commonwealth of Virginia, with the Virginia Department of Health, and it's exactly those kinds of questions they want. And so we spend a lot of our time setting up experiments, running the models, providing analysis that help answer those questions.
Thanks. It's very interesting and complex work that you do, and extremely helpful in understanding both disease spread and also how we deal with it as a population and as a government. And we're really excited to have you. As you know, this segment focuses on flattening the curve and social distancing. And these terms are not new to many of us anymore. They once were new. But I wondered if you could start with just a brief explanation of what flattening the curve actually means as someone in the field. Dr. Venkatramanan.
Sure. And again, as you said, like flattening the curve is a phrase that caught on as the epidemic started growing. And I think it's shaped the way people look at this pandemic and how all these responses have cropped up across the world. And the curve itself is a population level view of how the disease spreads. When we say the curve, we are talking about the epidemic curve, which is mostly like the new number of infections every day. And it usually follows a bell-shaped kind of a pattern. So you have early cases which are much fewer, and then as the epidemic progresses, it grows exponentially till some point, and then once it hits the population capacity, or like it starts saturating, and then you'll start seeing a decrease. So if an uncontrolled epidemic would actually grow until like it can no longer find new susceptibles, and then it starts decreasing. And so this is what we call as an epidemic curve. And there are different variants of this, where like instead of looking at number of new infections, you might be looking at number of new hospitalizations or deaths, and you might be looking at it different spatial regions. So instead of just looking at the national level curve, each region, like a state or a county, has its own curves, and they might be staggered or of different intensities. But yeah, so when we talk of an epidemic curve, that's what we mean. And when we say flatten, usually it means a combination of two things. First, you would like to reduce the intensity of the peak. So just since it's a bell-shaped curve, there is a point at which it attains maximum value, and you would like that to be lower. And the other thing is you would want that to be later. So so those are, and sometimes when you do that, as people who have looked at a lot of these graphs, we would like to understand this as like area under the curve. So you might say you can move this to the right and reduce the peak without affecting the area under the curve, which basically says you're still having the same number of people getting infected or same number of deaths overall. It's just later and the peak intensity is lower. But sometimes you can do things which actually reduces the area under the curve. So there might be different interpretations to what you do in terms of like flattening the curve, but essentially it's later peak and a lower peak.
Understood. And so that seems to be a very important difference, maybe by keeping, when you talk about the difference of keeping the area under the curve the same and just shifting the curve to the right, or actually bringing that area under the curve down. And so in a lot of the things that we hear kind of in common media and in the news today, are some of these techniques that we're talking about, would they actually just be prolonging the issue and maybe keeping that area under the curve the same? And so maybe a better way to ask that question is, what happens if we don't flatten the curve? And what happens if these case numbers kind of continue to be going in the same direction that they're going?
Right, exactly. Like, why is a flat curve better than a not flat curve? And I think the key issue there is that the ability to respond to many people getting infected definitely gets curtailed when there's too many people and the healthcare system can get overwhelmed. It's a situation that I don't think anyone would want to find themselves in, where COVID-19 patients are piling up in the parking lot. Obviously, errors go up, care is not able to be delivered to people, and therefore I'd expect a whole lot more excess mortality as well as morbidity. Not to mention the burden that it would put on healthcare professionals, your nurses, your doctors, everyone working in the hospital just would get crushed, eventually increase the risk that they would get infected. And then you start losing personnel that can respond and treat the society at large when they get sick and they are no longer able to do it. So you sort of have a double whammy there. And so we definitely want to avoid that, and a flatter curve decreases the chance of that happening. Additionally, by flattening the curve and prolonging it, you have less area that you've actually, sort of consumed yet. And then you buy time where other mitigations can arrive. And that would allow us to potentially prevent even having to go through those people becoming infected. If a vaccine were developed or a treatment were shown to be more effective, the people who then get infected in the later part of a delayed curve maybe have a higher chance of survival, less bad outcomes, maybe less transmission overall. You can even lower that area under that curve overall. And I think we're starting to see that right now. I think testing has been able to finally sort of catch up a little bit. The current state that we're in, we're seeing decreases in some of these key metrics about the amount of time it takes for people to get diagnosed. And we are seeing that in our models, initially we were seeing that we might be only a month or so away from when hospitals might be reaching surge capacity, getting overwhelmed. And that has been pushed further back into the future. And so those are all positive signs.
Awesome. And so I'm curious what ways there are for us, both as individuals and as part of kind of a broader city, county, and even country, to help flatten that curve. And do we actually see these methods working as they play out kind of in our real life data and in the models that you guys are working with as well.
Sure, and I can take that. So as we talk about flattening the curve, one of the things that has gone along with it is social distancing. And when we talk about social distancing, we are actually creating gaps through which gaps for the virus to not spread. So if you think of viruses spreading through human to human contacts through the social contact network, you're basically breaking the chains. So just like flattening the curve is a population level view of how an epidemic can be slowed, at a network level view, you're actually breaking the chains of the network so that it doesn't hop through the entire network. So if you think about trying to stop a forest fire, it's like creating a line of, you basically create a path inside the forest where like the fire cannot spread across. And so when we look at this kind of gives you an individual level view of how you can create these gaps. And for instance, when you're looking at it at an individual level, you by default, you have say 20 to 30 contacts in a given day. By reducing the number of activities that you do or the number of places that you visit, the crowd of places, you try to minimize the number of social contacts. And this also implies that like even among the contacts that you have, by practicing hand hygiene and healthy precautions, you try to minimize the chance that the virus could spread through these contacts. And so that's the individual view of it. Whereas at a population level, you can, again, the city or the county can decide that by closing schools or by reducing the people who are essential at the workplaces, you actually reduce the number of people who come in contacts. And by doing a combination of these measures, you essentially create these environments where like the virus spread is significantly slowed. And that again talks to this aspect of flattening the curve so that you're not overwhelming any of the healthcare resources.
Understood. Thank you. And Dr. Lewis, I'm curious if you could speak just briefly to some of the industrialized countries out there who have not gone into kind of the same type of social lockdown that we have. Take Sweden, for example, an example that we see in the news commonly today. How does this strategy work, and why might they think that it's a good idea?
Yeah, it's a really interesting case. Sweden's got a very well-developed healthcare system. And so I imagine that they wanted to take sort of a monitor and see if this becomes a significant problem. I think, every country's got a different set of issues, problems, cultural practices, etc. What might be acceptable and not acceptable. To be honest, I am really surprised that the US so willingly went into the degree of social lockdown that they did. I've been working on influenza pandemic preparedness for over a decade at this point. And one of the issues we talk about is like, we probably should close the schools. It has been well established that schools really are a hotbed and a conduit for a lot of the influenza spread, even though the kids themselves don't necessarily always get super sick. You can just see it go through the school populations and infect the adults and get up into the grandparents. And it's always been sort of a recommendation. If we could shut the schools for a month or so, if the pandemic were getting bad, then we could really slow things down, and that might buy us the time to get a vaccine out, etc. And there's been a significant amount of pushback. That'll never happen. It's impossible. No one will agree to it. It's a county by county decision, etc. And so to see the solidarity that our country undertook that was heartening and a little bit of a surprise for those of us who have been working in this kind of field where we look at non-pharmaceutical style interventions for dealing with a public health emergency. And so seeing Sweden not willing to do that or go after that didn't surprise me overall. And I do think it is down to just the efficiency in which they are able to provide care. They figured that if it got to a point where they were close to being overwhelmed, they would have levers that they could then pull to slow things down. And I think they wanted to just sort of keep things going as is. It seems like they've been having some issues there, but it seems like that they haven't gotten to the point of Italy or New York City, et cetera. And so it seems like their monitor, wait and see approach is working reasonably well. They're lucky in that they have a very homogeneous population. It's relatively small compared to the United States. It's a little bit more centralized. Population is probably a little bit more compliant overall, so they could probably have a little bit more faith that if they said we need to do this, people would probably do it. Whereas in America, much more diverse, much broader. Cultures are different in New York from Kansas to California, a little bit more challenging of a problem. And so I think they maybe felt they had a little better control over things. So I don't know if it was the best idea, but it hasn't worked out too badly for them.
Understood. And Dr. Venkatramanan, question for you. Something often mentioned but not frequently explained in the news these days is the use of predictive modeling. Could you talk to how these models work?
Sure. And I never thought a time would come when like mathematical modeling would mean something to my grandparents, or like modeling was something that was very restricted to like the academic circle, where we were looking at how to put all these data sets together to make sense of the world. And if you think about it, like physical models have been very useful for people for quite some time, like in the world of weather forecasting, or even if you go back to basic Newtonian physics, if you throw a ball up in the air, you can just write down an equation which says when it will come back and hit your head. And people actually have mental models which are not actually transcribed to equations, but they have a good sense of how things work. And essentially mathematical and computational models are ways of encoding this about things that you don't understand, especially complex systems. So while you can understand how a ball comes back and hits you, it's tough to understand how a billiard ball would go around in a kind of a billiard table. And as you start scaling up these systems, you rely on more and more computational and mathematical techniques. And this is just about physics. But as soon as you come to individuals, you'll have a lot more complexity that you need to account for. And so again, like as I said, there are these different scales of complexity that you need to handle by looking at the appropriate type of models. And one class of models that are easy to put together are statistical models, where if you have enough data, then you can say like infer the patterns in the data and then just project them forward. And we've used a lot of these kind of models for influenza forecasting, especially when you're trying to forecast seasonal influenza. There are a lot of seasonality patterns based on weather and just healthcare seeking behavior and so on, which you can encode into the model. And it's reasonably good at predicting the short term and even sometimes the seasonal activity. And the next class of models is what becomes important when you want to understand things like what would happen if we close schools, or what would happen if people start socially distancing, staying away from workplaces and so on. So those are the class of models which we call mechanistic models. And it tries to encode the mechanism of how the disease spreads through a society, either through just like capturing just the disease states, which like every person needs to go through a susceptible, exposed, and infectious kind of states, and also trying to capture some notion of how the society interacts, either the social contact network or how people move between counties or different regions. And so by encoding all of this, you give yourself some power to understand first how the data fits in, and using that just project them forward. So you just understand how the natural trend is, but more importantly, it allows you to play around with some of these variables, which you may not be able to actually experiment in the real world, but you can say like, let's try to close the schools, or let's try to see what would happen if we increase the testing rate. And so these models are good playgrounds, but also they help you build a good intuition about what policies might work in the real world. And also as policies are implemented, it helps you evaluate whether they are actually having the intended effect. So I would say they're cognitive extensions in their best use. Yeah.
Very interesting, and that's very helpful. Dr. Lewis, I'm wondering what you'd say about the relative accuracy of these models, and why we may hear about different models predicting different things and very different kind of shaped curves as we end up hearing about.
Yeah, so the accuracy of these models is always very challenging. I mean, when you're projecting into the future about a disease that is dependent on how people respond and undergo different behaviors, it's really challenging. I mean, it's basically impossible to predict what people are going to do and what actions are going to happen. Nonetheless, I think it's still very useful to be able to play out different projections or forecasts to allow people to see, like, if this trend continues, or under these conditions where maybe we are able to develop, do a more efficient job of testing and trace and isolate more people, how might we be able to deflect that trajectory? And so those kinds of counterfactual analyses are really good uses of these models. In terms of the accuracy of different forecasts, you know, one of the analogies I try and use is that imagine predicting the weather. That's reasonably hard to do very well beyond 7 or 8 days. I mean, at least from the weather forecast I see, it varies. We were supposed to have a ton of rain yesterday. We barely got any. It's supposed to rain all day. But, you know, and that's understandable. People are used to that. And that's with billions of dollars invested in sensors and reasonably well-described physical models. When you interface that with people, so imagine if the rain forecast mattered about how many people are actually taking umbrellas. They see a forecast that says it's going to rain all day tomorrow. The number of umbrellas go up. Maybe that forces the rain not to happen. We know that doesn't happen as much as it sometimes feels that way. You bring the umbrella, it doesn't rain, you forget it, it pours. And so in the infectious disease world, much like in financial markets, you have the same problem where if everyone knew that this stock was going to go up, everyone would buy it, and then that would make it go up even more or go down less because no one would want it anymore, et cetera. And so those accuracy levels may fall off quite a bit. Nonetheless, seeing a projection of where we are headed, and especially if you can put in different scenarios, I think is very useful for policymakers. And it gives them a little bit more than just eyeballing the current data and drawing a line with a ruler out to guess when they might need certain kinds of resources. And the other use of these models, again, as Srini was alluding to, as these systems become more and more complex, there's certain interactions that can happen that might be producing a counterintuitive result. And so if you put things together, you let the model run, and then all of a sudden it starts to bend in one way or the other at a certain point, just investigating what that might be might reveal a relationship that you hadn't realized to date is occurring. And sometimes that relationship itself in the real world is meaningful to point out. It might provide some insight into different actions that might be useful to undertake. And so that's what I see the point of the models are. It's not really supposed to be a crystal ball where you just say, tell me what the world's going to look like in 3 weeks, but it's supposed to allow people who are consuming these models to better understand the world that they currently exist in and how that might evolve over time under different assumptions.
Understood, and that's very helpful and very fair enough. Another thing that we hear commonly these days are about surges and how different cities and states might be experiencing different surges, might be preparing for different surges in cases. I'm wondering if you could define surge for us and tell us what the models you're working with say about when Charlottesville's surge may be and what it may look like. And then additionally, how will kind of the loosening social restrictions that we're seeing and will continue to be seeing in the coming weeks and months likely affect this surge?
Sure. And again, when we talk about surge, we're going back to this concept of flattening the curve. We're looking at all of these systems have, like if you look at the hospital system, it has some given capacity that it's operating under. So the number of beds, the number of ventilators, and even staff or PPE that you have. And one classic example that we saw during the COVID-19 unfold across, like for instance, in Italy and then in New York City, was that when the city is not prepared or when the region is not prepared for a wave of a pandemic, then you suddenly start seeing your demand for healthcare resources exceed your capacity. And this capacity could be either based on like already there are a lot of people who are occupying beds and ventilators, so you can't take them off that. So there is, even though you have 100 ventilators, maybe only 30 is available. But then there is another, what people usually call as surge capacity, which is what they have almost like in their savings account. So they have it in reserve for such situations. Sometimes you even exceed that because you never plan for an extreme surge, because if you think about it, it doesn't make economic sense or even like social sense to actually have like a ventilator for every person in the country. But when you have public health emergencies like a pandemic, you would like to make sure that you have a good sense of when the surge is going to come and how much the surge is. And through either preparing for your particular region by just manufacturing more, or cleverly moving around these resources across the different regions. If you understand, if say region X is going to experience it maybe 3-4 weeks earlier than region Y. And this is something, again, we saw in New York, where there was a lot of discussion of ventilators being shipped from California, because some regions were had gone through their initial wave. And so just understanding when you would need resources that exceed, or like when you would need resources to manage the demand that exceeds your current capacity, that's called a surge. And in the case of the models that we're running for Virginia, at least based on our current trajectory, which is we have kind of paused the growth. We've not actually grown at the rate we were growing at the before, like mid of March, through all of these social distancing measures. If at all we exceed any of these resources, it might happen in the early fall, and it might happen in the northern region. And for regions like Charlottesville, we don't see in the current state of the models any of the healthcare resources being exceeded. But again, like as you pointed out, as we are loosening some of these social restrictions, it's important to keep looking at the surveillance mechanisms that we have, like just the number of cases that are coming in, but more importantly, number of new hospitalizations and ICU admissions, to keep track of the data and keep adjusting the models. And this is very important because, like, it's not very useful to say that you've exceeded the surge when you've actually exceeded the surge. Any lead time that you can give helps people establish some of these makeshift hospitals, or just order some more ventilators. And that's what we've been trying to do as we are tracking this pandemic in this region.
One point to just echo on there, Srini, and we're always having to update these models because the disease spread is pretty stochastic, it's pretty random. Small events cause things to go one way or the other, and a lot of our current modeling on this is sort of more in expectation, sort of what the average trajectory might be. But it takes, one nursing home where the infection gets in there and maybe 20 residents get infected. We would see that, but we would sort of average it out in our model. And so when you get these slight upticks, you would get these little surges. And at least just recently, I've been hearing a little bit about the Hispanic population in Culpeper having a bunch of cases recently that were coming into UVA in the last couple of days. And so that's something that's a little bit different than what it was when we ran the model on Monday. And so now we need to ingest that data, re-update it. And you can think about it like with the weather models, they're always doing the radar, some cloud crops up all of a sudden in the middle of the day and like, whoa, we didn't think there'd be a thunderstorm, but it looks like there's gonna be a thunderstorm this afternoon. So updating these models and getting these pipelines where you can ingest and adjust to the current conditions is a really important aspect of this kind of work.
Understood. Thank you. And before we close, I wondered if either of you had anything else you'd like to share with our listeners that we haven't had a chance to discuss yet.
I'll take a quick shot and just say that, yeah, I appreciate you giving us the chance to talk here. And I think just in general in the public, and when people often hear about these mathematical models, they start to, their eyes glaze over because math wasn't their favorite subject in school. And I think Srini did a really nice job of summarizing it. It's just a way of turning into mathematical equations the way that we think the world works. Everyone's got mental models. This process basically takes those mental models, backs it up with data, and turns it into these equations. And then that is allowed to project. And so they're only as good as the data going in. They're only as good as the assumptions. And when we don't know a lot, like we don't in COVID-19, there's still a bunch of question marks, although more and more of them are being solved. The uncertainty can still remain high. And so I think for the public to view these as just sort of guides, coarse weather forecasts, rather than perfect crystal balls, I think is really important. And it should guide your decision-making. But just as you wouldn't use a weather forecast to say whether you're going to not invest in a tent for your wedding 3 months from now, that's an outside wedding or not, you should use this to sort of guide your decision-making, but also other data points and other considerations. It's just meant to be an endpoint into the, provide extra information to the decision-making process.
Thanks. I think that's very helpful. So at this point, I'm very sad to say that we're out of time for the segment. I want to thank you both again, Dr. Bryan Lewis and Dr. Srinivasan Venkatramanan from the Biocomplexity Institute here at UVA, for sharing your time and expertise with us. As unprecedented and unnerving as these times are, I think better understanding what's going on around us will help us to both stay more safe and more sane throughout this time. And so thanks again, and we all appreciate your work immensely.
Thanks for having us.
Yeah.